mental health and behavior stuff, and there's issues that a lot of people don't even know. So you have, like, in a community like New Britain, you have a lot of youth and adults who have trauma from high violence areas, high crime areas, you know, gangs, police, you know, so, and they don't even realize it, even in the high schools. So thank you very much, and I am going to ask you to come back to talk.
Really, before the meeting was even over, I was definitely on board and wanted her to come in and work with the kids. So I work at Community Central, and we sort of operate like a nonprofit with a very small budget. We're supported by CCSU. We are essentially CCSU's like face in the community. I started work here a year and a half ago, and I had to kind of hit the ground running. I didn't have a lot of direction. So I worked, I met people, I networked, and I met a lot of people who were from New Britain who really had a deep understanding of how to connect with the community. They were passionate, they had great ideas, and Larissa is definitely one of those people. So we have a high school after-school program, and we basically connected with an existing club at the high school called the College for Every Student program. So it's all kids who are interested in going to college. They mentor like children from North End Elementary School, which is right nearby, and their focus is on college readiness and mentoring and community service. So we started working with them, and this year we arranged to have them come to Community Central 3 days a week. They come to us on Monday, Wednesday, and Friday, and we just kind of throw activities at them because we're trying to figure out what they're passionate about, because we feel that when they find what they're passionate about, that will drive them to succeed. So I just try everything, and different students respond to different things, but I think that when Larissa came in and met with the kids, that was the first time that I saw all of them become engaged and get excited. Even kids who sometimes like act out or will be on their phones were just paying attention and focused and participating in the discussion. So Larissa's program is a departure from school in many ways, where students are told to behave and be quiet. Instead of that, she encourages them to question things and form fact-based opinions that they can use to support arguments. The program is teaching them how to communicate effectively. Larissa stresses the importance of respect and listening, tells them how to be confident in their opinions and to really know what they're talking about. So I'm really looking forward to working with her in the coming months and seeing how our students grow as they develop all of these skills that they're learning. And a lot of the students are struggling at home and at school. So in addition to the skills that they're going to be building, I think that this experience will teach them that they can do something and that they have the power to make things better for themselves and for their communities. So it was, I think, it was what's, it was in school. The prisons, right?
Yep. Yeah. There's a cell, a holding cell in New Britain High School. And so I was just asking them, so what's going on in your school? And they were like, you know, this goes on, that goes on. Well, there's a lot of very assertive, you can see they're miniature leaders already, young ladies who, you know, I think it's the students who keep acting up who's preventing me from getting my education, because they won't be quiet. The teacher stop teaching because they have to deal with them, and you know, and I think they're taking away from my education. Well, at the same time, the other students say, wait a minute, I'm dealing with real life grown up issues at home, and I don't have anywhere or anyone's talking to me dealing with mental health, right? And so sometimes in school is the only time I get a break. So I'm not really acting out. It's the only time I get to act like a kid, right? And so and then someone says, well, sometimes the teacher who has a non-caring attitude. And so then there was like this fight that happened because we got into the conversation about the security guards, and now there's a police station in the school, and you know, police officers are there. And one kid was like, yeah, I was standing in the crowd and there was a fight, and I had my hands up going, oh my God, and I was very excited. Well, security jumped over tables, they knocked over someone in that wheelchair, and I was like, you guys are exaggerating. It was like, no, it happens. And you know, again, dealing with people who have different issues, mental or physical issues, health care, and, you know, knocked over, grabbed me, slammed me down on the ground, put me in those plastic strips, and put me in the holding cell. And I said, a holding cell? They was like, yeah, a holding cell. I was like, you mean a classroom? You know, no, I was in a room by myself, and we call it the holding cell. And it was this young boy's experience. Oh, you weren't there for that. Yeah, was there. So he was telling that experience, and he said, you know, I'm glad that happened because I'll never get in trouble again. And I was like, so how long were you there? Well, until my parents came, because then they realized I wasn't involved, but I could have got arrested. It scared me to death. Now, you would think that's a good thing. Here's the problem. He sounded like an inmate. He sounded like someone who's been incarcerated. That's a symptom of an incarcerated community. New Britain is an incarcerated community. Whenever you have a youth of 14 years old saying, I was in a holding cell in my high school, but because I witnessed the fight, not because I was in the fight, and even if he was in the fight, why is he in a holding cell? And I understand it's all in the guise of public safety and security, but our high schools are not prison institutions. Our high schools are high schools. Kids fight. There was no weapons. It was just a fist fight. That was aggressive behavior. So the kids got into this back and forth argument. And that sparked a whole other discussion and another debate. And they started debating because as I started reading them stats and facts and gave them the fact sheet about New Britain stats, and it was like, and they were like, 53% of New Britain high school's population is Latino, but only 10% of us is graduating. That's sad. I said, so is it the teachers or is it the student? And so now they're doing research, and they're very excited. And they're gonna do a public hearing to talk about the importance of Hannah's program on this coming Thursday. And we're really excited about that. And that's just 3 weeks of youth. And so why the youth? Because the youth voice is very important. Youth voice is what's carrying us into the future. Youth voice has some issues that we don't even address. They have trauma issues. They don't even realize it. So if they don't realize it and their parents aren't familiar with it, how would they know? How would they know they need social services? How do you know they need mental health services? You know, some of them, their parents work, but they don't have insurance because either they only work 38 hours a week or 34 hours a week. They may get paid $17 or $23 an hour, which is like making that mark where you can't afford to be on Medicaid or Husky, A or B, and it's like, but that family is working poor, and those kids are struggling. So that's why you have this mixed group, because we're talking about what's coming down the line, what's been happening, what we need to change, and why we need to change it. And so now we can get into a dialogue about New Britain and how would this benefit New Britain. So we don't necessarily have to be in this kind of atmosphere. We can bring our tables up, and I'm just going to take notes as you guys talk and decide on some based on the data, based on what you've heard, how is this going to help a community like New Britain and thus Connecticut when we start utilizing affordable care? What does that mean? I thought that Marcia brought up a good point when she said about housing services being part of that, and also about people who already have services, but they get less. They already have insurance through their job or whatever, but they get less services, and they actually pay more. How are we going to make this equitable? How are we going to make it equitable not just for the working poor, not just for people who are incarcerated or formerly incarcerated, making that transition, but also how we're going to make it work for people who have insurance, who are working, and make sure that they're paying an equal amount too. And so that could be, you know, part of our little dialogue right now, or whatever questions you may have for the panel.
Subsequent to that for which you were arrested, let's say you were arrested for marijuana possession, you were going to be ending up in jail, but you bought it or sold it in a school zone, then you would have 2 years tacked on to the end of your sentence. In Connecticut, that distance around the school was 1,000 feet. A few years later, that didn't seem to be working, so a legislator suggested, and the legislature passed, increasing that to 1,500 square feet, 1,500 feet around the school. Once that was done, then for most urban issues, there really wasn't a space in town that wasn't a drug-free school zone. So the original intent, which was to provide a safe zone around a school or a sanctuary where this is one place where the kids will be safe, that was lost because there was no special zone. There was all the rest. Besides, studies in Massachusetts showed that most drug arrests did not occur while kids were in school. So that seemed a little strange. And in Hartford, only 11% of those people arrested for drug offenses in the city had this extra sentence tacked on. So it wasn't serving the purpose. And people began to think, well, maybe it's because the whole city is a drug-free school zone. Except now in New Haven, there was an area that was free, that was not a drug-free school zone. It was on the golf course. So, you know, so people said, well, let's cut this back. And so this year, after a previous attempt failed, the Sentencing Commission asked a group to get together and talk about what would be some logical things that could be passed. And there were several suggestions made, and the Sentencing Commission then chose 2 of those things to present to the legislature. And those 2 things were to decrease the distance to 200 feet from the edge of the property. Before, it wasn't really clear where you were starting to measure that 1,000 feet or 1,500 feet, but it didn't make any difference because the whole city was a drug-free school zone. But once you shrunk it down to 200 feet, it needed to be clear that you were talking about from the periphery of the school or from the daycare center or from the public housing. And the second thing was to make sure that you couldn't be arrested and have these enhanced penalties applied if you were just driving through. Even if you had drug stuff in your car, or even if you were doing a drug deal as you were driving through the school, you could not be arrested. You could not have the enhanced penalties for doing that in a school zone. You could be arrested for having done the deal, but you couldn't be arrested and have that enhanced penalty tacked on. There were some other things that were discussed and were not decided, but those are the 2 things that were chosen and will be and have been presented to the legislature for their consideration. That's it in a nutshell. And if there's more questions, we can answer them later. But that's just sort of.
Did you explain the intent piece?
Yes.
Okay. And so, one thing that happened last session, which I thought was very great, was that
their children, their dependents, up to the age of 26, which is very nice. I mean, I have a 21-year-old, and I can not worry about whether he's going to have a job with insurance when he graduates from college in May. And so that's a nice perk, you know, that we are able to figure out a way to cover our young people when it's hard to get jobs. Starting in January, people who are eligible for Medicaid, that will be expanded such that people that are at 130% of poverty level will be eligible for Medicaid. That's a big deal. A lot of the people that I work with have been not able to use Medicaid because they have a spend down, because they have an income that's over $500 and some. And so even though that's not enough to live on, they have to spend their own money for a certain period of time, which they never come up to the point of being able to come. And then in 2014, we have something called the health insurance exchanges that are going to be available to people. And there will be subsidies for people with low income, so there will be the possibility for people to be able to purchase insurance who could not afford that before. There's lots of complications around that, but it's something that we hope will offer insurance coverage to people that have not been able to afford it before. And then one of the things that I think is very exciting is that there's been the encouragement of integrated health systems, which means really understanding that behavioral health and physical health are integrally related. And so how do we make sure that the provider systems are working closely together such that when someone has a physical concern and has a behavioral health concern, that those providers are working together? Can they even be in the same place? So that if I come to see my psychiatrist and the medications that I'm taking also give me high blood pressure, that I can just go next door and have a physician that will help me with that. And can I have screening on both sides of those doors to make sure that all of the issues that I really have trouble with are being dealt with by people that are talking to each other and talking to me. So there's a couple of things, or there's a few things that are being created that, and again, it's really complicated to think about how this is going to work out, but there are things called health neighborhoods that are being created, and these are for individuals that have, that are covered by Medicaid and also by Medicare. So we have two payment sources, and they're looking for these providers of service to be working very closely together, and for often the health neighborhood is kind of maybe centered around a physician practice or a hospital, but they have to have all the specialties connected to them, and they have to be communicating and working together so that that person has integrated care. And then through the mental health system, they're also talking about a similar thing called a health home, where it may start out with the behavioral health center, but again, how do you make sure that people's physical health needs are taken care of? And for people with severe mental illness, this is a really serious concern, because the statistics say that someone who has severe mental illness, their lifespan is about 25 years shorter than the general population. And it's not because of the psychiatric disorder. It's because of physical health concerns that occur because of the treatment of the psychiatric disorder. So, you know, many of the medications that they take cause other chronic illnesses that are killing them. And so what are we going to do to make sure that we screen and treat for those illnesses? So that's an important thing, that this integration will occur. And through that integration, they're also looking at you know, not just you pay a doctor to do a service, but what are the outcomes of that service? And so there are things that have not been built into medical practice that are being talked about as important within these. So for example, if somebody doesn't have a place to live, they don't have the basic foundation of a secure place to live, then does anything else work? And so is having secure housing an outcome, or is it actually a service within that? And can that be funded? So they're really looking at, can supportive housing be a part of the funding mix in integrated health care? Same thing with case management. If you leave a medical practice and you don't have somebody who's kind of helping to follow up to make sure that you are getting the care you need, what falls apart? And so does that need to be built in? Because typically in the past, you know, everything is fee for service, and you don't get those kinds of things that tie it all together. And so it's an interesting mix, and it's, you know, it's hopeful for me, because we found that those kinds of services really make the difference for somebody that has behavioral health concern. So those are kind of real positive things. Some of these things are already in play, some of these things are coming down the road, but they're all things that are kind of hopeful things for us. Things that we have to contend with. All of this means that there's a real shift in funding streams in terms of the provider network and the reimbursement rates for services. And so I've spent quite a bit of time at the Legislative Office building in the last month or so testifying on different bills that have come forth. And there's a lot of concern on the part of the provider network that there are services that have been funded And Connecticut is really unique in this area. Connecticut has funded a lot of things through state funding that many states have gone to Medicaid fee-for-service for. And it has allowed some flexibility, and it's also allowed a reimbursement rate that is actually manageable by the community mental health system. And so there's a lot of concern that the reimbursement rates will go down, the number of people that are eligible for Medicaid services will go up. The providers are already kind of at the breaking point in terms of what they can do, and will we be able to handle the number of people coming at us and the rate of payment that comes with them, and will the system just break down? And because access is already limited for many people to services, will that just get worse? And so there are bills coming before the legislature saying, let's at least study this before we reduce state funding that says we're not going to pay for this anymore through the state. Can we at least study this and figure out the impact before we make a reduction that we can't live with? So that's important, I think.
Which bills, do you know what they are?
There's a bill called 1026, Senate Bill 1026. An act concerning an adequate provider network to ensure positive health outcomes for low-income residents.
Very good.
Yeah. And the testimony on that was, I don't know.
It's okay.
I'm so tired of which one we tested. But I did grab my notes on that. But that's important. And then also, if all of this changes, as all this is changing, can we think about, because one of the things that happens is as things change and somebody becomes eligible for Medicaid funded services, you can't supplement that to the provider with state funds. You can't say, well, it doesn't pay as much as it costs you to provide the service, so we'll give you a little bit extra to continue that. Once the person is eligible for Medicaid, that's what you have to take. And so there are some state funds that will be reduced for that service. They have to be. But there are things that Medicaid doesn't pay for.
Okay.
Can we reinvest those funds in things that make sense for people, or just go in the general fund and get lost in behavioral health? How do we think about that? So those are important things to be thinking about, because there are things that really work for people. There are things like case management. There are things like support employment. There are things like supportive housing that are not clinical, medically necessary services, that are not covered by Medicaid, but they make all the difference in the lives of people. And so rather than just stick all those funds in the general fund, is there a way to reinvest those funds in things that really supplement and make a difference? And not just augment, but sometimes actually replace medical services for someone who has behavioral health needs. So we really have to think as a community about how to do that. And so the legislator at this point is being asked to really explore that and not just cut too quickly. The thing that, there's some other things that are of concern. Because we're in a budget deficit, the state is looking for ways to save money. So with this Medicaid money coming in, they're saying, so what can we do to save money? And so, for example, there was a waiver application from the Department of Social Services last summer, I think, which said, okay, so there's these young people that are not covered by their families, covered by their family's insurance, so let's make a rule that anyone who is 18 to 26 now has to be covered by their parents' insurance. So if indeed they're 18 to 26, and even though they qualify for Medicaid, let's make the parents pay. Let's make that a rule. Let's tell the feds we want that to be a rule. And so they posed that. They signed it. They filled out an application. They sent it to the feds saying, we want this rule because this will help us to figure things out and reduce our costs. And so there was a lot of advocacy on the part of the people who felt that would be harmful to young adults. to say, please don't do this. And actually, Monday, we got the notice that the feds had said no to that. But now there's another proposal that says, okay, those people that have between 133 to 185% of the poverty level that are parents, that are now what we call Husky A, so their kids qualify for Husky B, but parents get Husky A because their kids are in Husky B, and they're poor, but they're not the poorest. Well, we're going to throw those people off now. So again, advocacy, but it's a way to figure out where are we going to save money. So let's try this one. So there are going to be all kinds of efforts because of the deficit to figure out how can we use this new Medicaid money to save money, and who can we throw off to do that, and what's the harm. So we have to be really vigilant. And then the last thing, I think I have 30 seconds on it,
Yes.
is parity. There are lots of people that are covered by insurance that are not in the public healthcare system. And they get, in many cases, much less in the way of behavioral health services than people in the public health system. They're not eligible for case management, they're not eligible for supportive housing, they're not eligible for supported employment. Those are things that come through the public health system. And so, is that right? What can we do about that? If I had a heart attack, I was in the hospital, and I had to go to rehab, that might be covered. If I have a psychiatric disorder, I'm an inpatient, and then I need a step down, which might be called rehab, that's not going to be covered by most self-insurance, by most insurance plans. Is that right? Is there anything we can do about it? Even if it is what is affordable through insurance, is there a way to fund those recovery supports for people, especially young adults, who this is their chance to find a life? Is there a way to cover those in some way? So those are all things we need to think about.
Thank you.